Rectal palpation, recto-abdominal palpation. The prostate and, in most instances, the seminal vesicles may be felt by a finger introduced into the rectum. Preparation of the examiner. The examiner may protect his finger by a simple lubrication or by a rubber glove or a specially constructed rubber shield. The best protector for the finger is a rubber finger cot, a new one for each examination, and a shield for the rest of the hand, made either by winding a gauze bandage about the finger or by tearing a hole in the midst of a small square of absorbent cotton. The finger cot must be lubricated. In his other hand, the examiner holds a piece of gauze with which to wipe the grease from the patient's anus after the examination. Preparation of the patient. The patient's bladder should be moderately distended, preferably with boric acid solution. This is to be urinated out after the examination. Position of the patient. Some prefer that the patient should be upon his back with his knees drawn up. Others that he should assume the knee-chest position. Others that he should bend over a table with his heels apart, his toes turned in, his knees slightly bent, his back swayed. Most patients can be effectively examined in the position last described. With his left hand upon the patient's left shoulder, the examiner may exert counter pressure to drive his finger as far as possible up the rectum. The examiner may steady his right hand by bracing the elbow against his right knee. The examination. As the index finger is introduced with its sensitive pulp forward toward the anterior rectal wall, it slips through the two sphincters and enters the rectal cavity above. Examination of membranous urethra and perineal body. With the index finger hooked down and the thumb on the patient's perineum, an examination of this body may be made for indurations, calperitis, periurethritis. Just above this, the finger in the rectum feels the membranous urethra, an almost imperceptible cord about 2 centimeters long in the median line. Boggy, lumpy, or tender infiltrations may perhaps be felt about it. Examination of the prostate. As the membranous urethra is followed up the bowel, it disappears within the apex of the prostate, which is felt beneath the anterior rectal wall. The normal prostate, as felt from the rectum, is heart-shaped, with its apex joining the membranous urethra, its base more or less notched in the center, its lateral lobes quite elastic, its central groove between the two lobes more or less marked. The normal prostate does not project into the rectum. Its lateral lobes are flat rather than bulging. Its outline is a little vague. In order to examine it carefully, the finger must be swept over its surface and around its borders. Great experience is required to recognize a normal prostate. So varied are the degrees of sensitiveness and of prominence of the organ, so frequently do we find phlebolyths or enlarged glands lying upon it or near it, that the specialist is frequently compelled to confess that he can find nothing abnormal in a prostate that has been pronounced diseased by a less experienced examiner. The clinical signs of a normal prostate are: the lobes are flaccid, flat, insensitive. An exquisitely sensitive prostate, like an exquisitely sensitive urethra, may be anatomically normal. A sensitive, intense prostate usually contains pus. A prostate with rounded, tense, insensitive lobes is usually hypertrophied, but may be simply inflamed. The relative roundness of the lobes is appreciated by sweeping the finger across them from side to side. A prostate may be inflamed or enlarged or the seat of neoplasm and yet feel normal to rectal touch. Cystoscopy and rectal palpation upon a sound in the urethra, page 315, are of great assistance in diagnosis of carcinoma of the prostate. There are no indurations in or about the prostate. Discrete round masses on or near the prostate are usually glands or phlebolyths. Indurations within the lateral lobes or projecting toward the seminal vesicles are usually inflammatory. They may be tuberculous or neoplastic. Indurations extending from the prostate into the base of the bladder beyond are invariably neoplastic. Examination of the vesicles. The distinction between the seminal vesicle and the ampulla of the vas is not possible by rectal touch. If the perineum is deep or the prostate enlarged, it may be impossible to insert the finger far enough up the rectum to reach the vesicle. The normal seminal vesicle is impalpable. The dilated or inflamed seminal vesicle is felt as an irregular, elongated mass beginning just above the prostate, laterally, and extending upward or upward and outward beyond the reach of the finger. If greatly enlarged, the vesicles may meet in the middle line, but usually there is a space about a finger's breadth in width between them. The inflamed vesicle feels doughy and lumpy. Examination of the vesicles may sometimes be made easier by counterpressure on the hypogastrium. A vesicle may be inflamed and yet feel normal to rectal touch. Examination of the base of the bladder. Neoplasms of the bladder and large stones in the lower end of the ureter may sometimes be felt by rectal touch in the space between the vesicles. Counterpressure on the abdomen is of assistance in this examination. Abdominorectal palpation sometimes reveals stones in the bladder, but in this respect, the examination is likely to be extremely misleading.